This narrated PowerPoint will take you through the remainder of the examination lab manual, and it is a sample objective outline with clinical applications. So you'll see that this PowerPoint is organized by topic heading. Some of the headings we'll spend more time on than others. Some will reference you back to the narrated podcast videos for some certain tests and measures such as balance and postural control, tone, and spinal mobility. And then some sections we deliberately are just going to review in a rather cursory way because we're holding those major categories for examination in the spring semester when we talk about the adult population. When first beginning any examination, you should be looking to gauge where that child's gross motor function capability currently is. So this is basically a movement observation of the child playing or moving within the environment in which you're conducting your examination. So you'll observe them in their age-appropriate developmental positions, such as prone or supine, all the way up through modified plantigrade and walking. And you want to take a look at how the child functions within these positions. Are they able to independently maintain these positions? Are they also able to independently assume these positions? So what do their transitions look like? And you're taking all of that information and you're comparing it to what you know typical development should look like at those certain age groups. From there, you'll be able to determine whether or not they're on track developmentally for their age, or if you are suspicious of certain delays, which will then lead you down a road of tests and measures. So you're going to meet the child wherever they are from a functional perspective. If they're able to do higher level skills, you want to make observations of those skills as well, such as galloping or skipping, hopping, jumping, stairs and curbs, so on and so forth. And then the converse of that is if the child does have more restricted mobility and needs to use a wheelchair or some sort of walking device, you're going to want to be in observation of those skills as well. So when we think about doing observation of function, typically not a lot of handling occurs here. We're sitting back, we're playing with the child, we're watching, and we're making observations. What they're able to do with how much assistance, what does the movement quality look like, what is their alignment like, are they able to initiate these movements and sustain and hold positions and then stop moving when appropriately? How do they move through the stages of motor control? Does it depend what developmental position they're in? So we're really just gathering a lot of information just based off of our functional observation. And this starts your thought process as to why is the child moving this way? Why is the quality of movement what you're observing? And that's going to help you then pick appropriate tests and measures to tease out the reasons for the why. Examination of gait is an area that you already have a lot of background knowledge and skill on when we think about being able to appropriately examine an individual's gait pattern. We know that we're going to start by looking at that gait from a variety of different advantages, anterior, posterior, from left and right, to be able to make sure that we're really picking up all of the deviations that are present in that specific patient. When we talk about pediatric gait, we do still need to consider all of those areas that you talked about last year as it relates to stance phase and swing phase, but there are also other parameters that are specific for our pediatric patients. It's really important that you have a good understanding of the bony development of a child so that you can understand the kinematics of developing pediatric gait and be able to compare that to a typical performance. So you have to kind of understand that orthopedic kinematic aspect of pediatric gait so you can understand if what you're looking at is typical or if it's deviating from typical. The other aspect with pediatrics that I think is really important is to be able to consider the functionality of the gait. So by that I mean just more so, can they walk in a straight line? How are they doing that? Can they start their ambulation appropriately? Can they stop ambulating when they need to? Are they able to turn? Can they turn left and right? And then what is the distance they can go, and thinking about distance over time. And we'll talk specifically about some of those standardized outcome measures as we move further on into this course. So the functionality of gait as it relates to those parameters, as well as where does this child need to walk? Are they primarily at home because you're dealing with maybe somebody who's 16 months old and they're home with their family during the day? They may not wear shoes in their home. Versus, are they at a preschool? Are they school aged? Do they walk outside a lot? So thinking about what does that child need to be able to do to fulfill their role from a participation level, and then examine gait under those conditions. So you might choose to do a gait assessment with shoes on or shoes off, with the orthotic device on, or perhaps they use an assisted device and you make some of those comparisons. So really thinking about the functionality of the gait. And then the third piece that I'd ask you to think about a bit is that might be different than what you did last year, was really how are you going to maintain your patient's safety during a gait assessment. There are a lot of variables at play when talking about pediatric gait, and you need to consider how are you going to be able to pick up on all of the deviations while keeping this patient safe. You may need to have a parent or caregiver walk alongside them while you take a look at the gait. You may need to get permission to record your patient and then go back at a later time and look at those. But some of those considerations need to be thought out ahead of time, because it's unlikely that the child will just walk right beside you, as perhaps some of your adult patients did. So you're going to need to plan ahead to make sure that not only can you get the information that you need, but first and foremost that the child is in safe hands while doing so. Another important area that physical therapists will assess during an examination of a pediatric patient is that child's fine motor skill. And you will be learning about a variety of grasp and release patterns throughout your typical development lectures, and those will be important so that, again, you can observe what the child is doing as it relates to grasping and releasing, and be able to determine if that is an age-appropriate grasp pattern or if perhaps they're showing a delay in that area. So when thinking about a fine motor exam, we want to look at how that child reaches and approaches an object. So how do they get their upper extremity to the object? Do they have proximal control in their shoulder joint to be able to allow that distal fine motor control, because you need to have that proximal stability to have distal mobility. So how does the child reach and approach the object? Are they able to reach across midline? That's a really important aspect to see if they can integrate both their right and left sides of their body. So reaching across midline, retrieving objects. Grasping and release, again, we talked quickly about that. You want to know what type of pattern they have. You want to be able to name that pattern and then compare it to what you would expect that individual to do at that age. And then the manipulation of it. So can they use both hands? Can they transfer an object from one hand to another hand? Is the manipulation efficient and functional? Do they continue to drop the object? So those are the types of things that you'll be looking for during your examination. And it's important to note that a child really should not develop a hand dominance or preference before the ages of 4 years to, some sources say, even up to 5 or 6 years of age. So if you see a strong hand dominance prior to that time, if you have a 2-year-old, for example, that really is only wanting to use their left hand, that should send off a bit of a red flag to you, because a child should really use both hands freely during that time period. So we start to think that perhaps there's a challenge with the other side of the body if they're only using that one side early on in their development. So can the child use both hands freely to play and to be functional? Another reason why it's really important to be able to understand the fine motor development of a child is that you may be the only related service provider seeing that child. So if physical therapy is the only one in the home and the child is presenting with a fine motor delay, you need to be able to pick up on that so that you can then make the appropriate referral for an occupational therapy evaluation. So you really need to be on top of areas that other disciplines may have an increased specialty in, but we are certainly well positioned not only to examine these areas, but to treat some of those fine motor areas as we're working with our patients. Another area that you need to consider and develop skill in being able to examine during your physical therapy assessment is that child's oral motor skill or ability to either self-feed or to be fed. So you want information pertaining to how does the child actually consume food and liquid. Are they on a regular diet? Some children are on a specialized diet where the texture has been thinned, or a puree diet so that they can safely consume those products without choking. So you want to have an understanding of, does the child take food orally? If so, is it of a regular texture? Is it something that has been ground up for them? Is it more of a liquid? So you want to have an understanding of that. And certainly if the child is on tube feeding, you would want to have that information as well as it relates to when the child is being fed and how they tolerate that. And then the other important consideration is, how is that child positioned while they're being fed? Are they positioned safely? So some children don't have the head control or the trunk control to be able to hold themselves upright. And if you've ever tried swallowing with your head not in a neutral position, it's significantly more challenging than being in a nice neutral alignment. So sometimes the physical therapist will provide that consultation, this is beyond the examination, to those other related service providers such as OT or perhaps speech, or even the parent, to make sure that the child is positioned safely during all feeding times. The next area that we'll talk about as it relates to our physical therapy examination is an examination of that child's speech and language development. Certainly we can understand that communication is of paramount importance to be able to have a successful treatment session. So you need to really have a good understanding of how that child communicates. It may be verbal, and you can certainly comment as to a gross number of words for their vocabulary, but it also may not be verbal, and you have to understand what their nonverbal strategies are to communicate. So some children communicate through sign language or gestures. You may need to read their facial expressions. Some children have augmentative communication devices such as a Dynavox, which you can see pictured there on the left, or something a bit more simplistic as a flip book. There's lots of deviations. They may be on an iPad. There could be jelly switches hooked up in which the child activates the switch with their hand and then their device speaks. So you have to understand how their device works, and hopefully that child has their device with them throughout the assessment so that they can communicate with you, as that is so important. And then you need to understand the difference between the child's receptive language skills and their expressive language. So receptive being, do they understand what you're saying, versus expressive, can they express their needs and wants to you? So those are two different skill sets, and you have to be able to tease those out. Again, you aren't the speech language pathologist, but you are skilled in being able to examine these areas. And then if you do determine that you suspect a delay in these areas, that is the point in which you would make the recommendation for a speech and language assessment. Next, we'll move into a brief discussion on examining behavior and intellect in our patients. You'll note that there's an asterisk next to this category, and that's going to designate that we will be giving you more of this information in much greater detail next semester when we talk about our adult patients, especially those who have had some sort of brain injury. You'll also be getting some of this information this semester in PT 532, your motor control and motor learning course, and we need to be aware that we should be taking a cursory look right off the bat of a child's arousal, attention, and cognition. That is going to impact their ability to follow our instructions through both examination and intervention, as well as their safety awareness as we're responsible for them during an exam and in treatment. So you're going to want to have a good idea of where this child functions from a attention perspective and a cognition perspective. Next, we'll talk about the child's ability to care for themselves in a variety of different environments. So this is essentially a detailed activities of daily living exam, and we're going to think about gaining this information through observation and through questioning across all of the environments that the child functions in. So that could be school, it could be home, it could be out in the community, in their church. So we really want to have a good idea of what are their ADLs like across these environments, because we know that performance on these tasks could change depending on where the location is and potentially the equipment that they have access to as well, and just what the environmental setup is like. So first we'll talk about our two basic types of ADLs, B ADLs and I ADLs. So B ADLs are those basic ADLs. Those are what you need to do on a daily basis to move around and care for your body. So those are things such as bed mobility and transfers, getting dressed, brushing your teeth and hair, bathing, toileting, eating. Those are your operational definitions of what a basic ADL is. When we think about instrumental ADLs or IADLs, those are a bit different. Those are what do you need to do to be independent in your everyday life. So for example, the basic ADL would be the eating, but the instrumental ADL to that task would be preparing the food. So maybe you're looking at that child's ability to make a peanut butter and jelly sandwich as an instrumental ADL. So it's what do you need to do, home management tasks, to be able to be independent. Those could be chores around the house, feeding the dog, maybe an older individual paying the bills, being able to use the phone. So the IADL is really the instrumental aspect, is what gives you the independence to perform your role across those different environments. And then you're also going to want to take a look at how that child does with work and tasks within the environment, and what are their body mechanics like and their ability to make those postural adjustments when the environment changes. Lastly, when we think about examining a child's ADLs, we also really want to have a good idea of what type of adaptive equipment or assisted technology that the child needs to be able to be at their highest level of independence. So if we're thinking about feeding, the child may use a variety of different therapeutic feeding equipment that we'll see on the next slide. So you're going to want to make note of that as it relates to their management needs to complete their ADLs. Examination of any orthotic or prosthetic device that your individual may use would be an important part of their examination. It's going to really help paint a good picture as to what that child needs to be able to function as independently as possible. We aren't going to spend too much time here in lab right now talking about orthotics and prosthetics, because in the spring semester you will have an entire course dedicated to exactly that content, where we'll go through orthotics for the first part of the course and prosthetics in the latter part of the course. But being able to have some skill in this now will be appropriate as you work with patients in clinical exposure and you have observations of different children throughout that course. So some basic pieces of information that you would want to know as it relates to that child's orthoses is how long have they had that device? Are they tolerating the device well? Do they use the device? So just because a child has a certain type of orthotic or brace doesn't mean that they are compliant in using it or that the family values that piece of equipment. So you want to know if they use it, and if not, why. Maybe it doesn't fit, maybe it was causing skin breakdown, maybe it needs to be adjusted. So there could be lots of reasons for that, but those are part of the pieces of information that you're going to want to have. Does the child need assistance in donning and doffing that device, or are they independent? So those are the pieces of information that you'd like to get additional information on. And then you can assess a child's function with and without those orthotic devices, and that's really important because you may find that the orthotic device isn't doing what it was intended to do. Maybe the child functions better without the orthotic device, but maybe it's a trade-off because you realize that kinematically they're aligned much better with the device. So again, we will have an entire course on this next semester that will give you the information you need to really thoroughly do an examination of the individual's orthotic device. But you have some basic starting information here, knowing that you're going to want to look at function with and without whatever device the child is using. As previously mentioned, examination of a child's assisted technology and adapted devices that they may use throughout their daily activity is a very important part of a pediatric examination because it helps you gauge how much assistance and how much modification a child needs to be able to perform at their highest level of independence. So you're going to want to ask about what assisted devices children have, and then there is again that difference between what does the child have and what are they actually using on a daily basis. So you're going to want to ask questions, you're going to want to observe the child using a variety of the different types of assisted devices and adaptive equipment that they may have so that you can evaluate its effectiveness or lack thereof. So I've listed some examples there for you. You may be examining a child using their wheelchair, looking about wheelchair propulsion, distance over time, their ability to independently buckle their seatbelt or swing away their leg rests, those sorts of things. They may have a power wheelchair. So lots of different types of equipment and assisted devices that child could have, but you're going to want to look at their function with the device, and then if possible to some extent without the device. You're going to want to know the difference between devices that they use in school and devices at home. So are they the same? Are they different? And what is the reasons for that? Does the child require any environmental modifications? And that could be, either at school or home, but they may have a ramp to get in if they're in a power or a manual wheelchair. They may need widen doorways. They may need specialized bathing equipment. There are a lot of different types of devices, and you're going to get a lot more information on this when you get towards the end of the semester, where you have a few lectures on assistive technology in the pediatric population. We'll spend some time over the next few slides talking about the importance in the detail that's required for the motor system exam. So this is really where you're going to be examining and assessing that child's muscle performance as it pertains to their everyday functional activities. In the motor system exam, there are several components such as tone, involuntary movements, strength, power, and so on and so forth. Any aspects related to tone, I'm going to refer you back to that specific narrated PowerPoint and video supplement. All of the detail is in there and in this portion of your lab manual. So we won't go back through and summarize that here. As far as involuntary movements go, you're going to be getting a lot more information as it pertains to different sorts of movement qualities such as tremor or athetosis, chorea, hypotonic movements, so on and so forth, as you start in with your atypical development lectures in a few weeks. One of the most important areas of the motor system exam that you could evaluate would be the strength of that individual child. You have a lot of experience here already in examination of strength, and you've learned some standardized ways to do that, such as the manual muscle test, which we will touch upon in just a few minutes. But a pediatric strength assessment is going to vary from perhaps what you were exposed to last year in your first year orthopedic content. There are many variables that you need to take into consideration when thinking about examining a child's strength as it relates to their age, their ability to follow your instructions, any cognitive challenges they may have, any tone or spasticity that might be present that makes it challenging to tease out whether or not you're feeling the child's tone kick in or this is truly strength. So there are a lot of different considerations in this pediatric population, especially if you have children with any sort of tone distribution that perhaps you hadn't considered last year. Having said that, strength is extremely important, and usually there are strength underlying causes as it relates to children who have developmental delays and delays in balance and postural control. So we want to make sure that that strength is a priority. So how do we test strength in the pediatric population? There are several ways to do that. We really spend a lot of time in observation of that child's functional skills. So you're going to have the child be playing, engaging them in activities, and you're in observation of what the quality of their movement looks like. By looking at the quality of that movement, then you're making inferences and deductions about what their muscle strength may be based on those observations. So you have a frame of reference for what typical movement should look like, and when you see that deviate from that norm, you're going to start thinking about what could potentially be the underlying strength challenges that would cause this deviation. So examining strength in a functional way just really requires the therapist being in keen observation of what that child is doing and then drawing those inferences later. The disadvantage to this approach, of course, is that you're not targeting one muscle group at a time, and you may have to make inferences about muscles surrounding a joint or more than one muscle that contributes to that motion. But it is a good way to be able to examine strength in the pediatric population and make those inferences and then go from there with additional tests and measures. You could, of course, do a manual muscle test as how you learned last year, so nothing really changes about that procedure. The hand placement, the positioning, the reliability of the scoring is all similar to what you've done last year. But there are a few drawbacks to this in that the children may not be able to follow your instructions, number one. If you think about the words that you told your adult patients, moving through a range, holding at end range, they may not be able to follow those instructions. Depending on the position, the child may not be able to independently assume or maintain the standard testing position for manual muscle test. So there are some disadvantages as it relates to that. One of the largest disadvantages, I think, is that if you think about the functionality of a manual muscle test, it really is only giving you strength about that strength of that muscle group through that range of motion. And it's really not very, very specific beyond that as it relates to function. So you could have a patient who is testing out fairly well, a 4 or higher on a manual muscle test, but still have real functional challenges because you've only looked at that over one snapshot in time. It's also challenging when a child has spasticity to try to figure out if their spasticity in a certain muscle group, let's say their biceps, is what is causing them to appear strong in certain shortened ranges, or if they truly have strength there. So there are certainly challenges as it relates to being able to tease out the difference between spasticity and strength. And then there are other objective measures such as handheld dynamometers, which I'm sure you're familiar with. There are normative values for those. Again, that's that same type of isometric muscle test. And it is good objective information to have as it relates to hand strength and grip strength of those intrinsic hand muscles. But it can be unreliable, and then you have to think beyond just being able to have information as it relates to strength of those hand muscles. In addition to strength, you want to consider ways and strategies in which you can examine both power and endurance in the pediatric population during an examination. When you think about the concept of power, this is really taking a look at a child's ability to perform a near max or maximal contraction or force multiplied by velocity, and this is usually over shorter periods of time. So example of tasks that would require power, if you think about the gait cycle, pushing off for gait, pushing off for running, those are examples of maximal force over velocity to give you that burst so that you can get up off the support surface. You could think about that same concept with jumping and hopping, throwing a ball, sprinting. So that's that individual's ability to generate power or force over velocity. And usually, like I said, for a shorter period of time. That's not something that you're going to be sustaining because it is short bursts of a lot of muscular activity. As opposed to endurance, this is the muscle's performance at a lower level or a sub-max force, but it's going to be over a more prolonged, continuous period of time until the muscle becomes fatigued. So when you think about examining endurance in a child, you might take a look at their ability to maintain a certain posture over a period of time, so such as sitting balance. Maybe the child can only maintain an upright sitting balance for 30 seconds before they start to show compensatory passive strategies like rounding their shoulders in a posterior pelvic tilt. That would be an example of muscular endurance. You can also examine endurance over multiple repetitions, so having that individual perform multiple sit to stand transfers or floor to stand transfers. Thinking about ambulation is a repeated activity that is continual over a period of time, so how long before they fatigue. Other higher level gross motor skills such as galloping or skipping, stair climbing, those are all ways in which you could get information about an individual's muscular endurance. Examination of reflexes will be covered this semester in the pediatric content. Learning Activity 3, along with the narrated PowerPoint and video supplements, will be your primary source for this content. You'll be getting information about different categories of reflexes. You already have some baseline knowledge on primitive reflexes, but the majority of this semester will focus on developmental and neonatal reflexes. Those are the reflexes that you will be held accountable for on mastery and throughout assessments this semester in this particular course. Protective extension, writing reactions, equilibrium responses will also come up not only in this course in your human motor development lectures, but also in PT 532 when you learn in more detail about balance and postural control. Examination of balance and postural control is a very vital component of a pediatric examination and assessment. I'm going to refer you back to the narrated PowerPoints with the videos that were constructed to show you the technique to be able to accurately examine static, dynamic anticipatory, and dynamic reactive balance and postural control. Recall that balance and postural control is not a standalone impairment in and of itself, but that there are many underlying impairments that contribute to deficits in balance and postural control. So as you're doing these tests, you should be asking yourself, what information does it give me, and what other additional areas do I need to examine? So children can have challenges in balance and postural control for a variety of reasons. It could be a range of motion challenge. Perhaps they're restricted. That doesn't allow them to display appropriate mature responses. They could have deficits in strength, which would contribute to challenges in balance. They may have diminished coordination, proprioception. They may have challenges with spasticity or hypotonicity. So there are a lot of different underlying impairments that can potentially feed having a challenge in balance and postural control. But it's important that you know how to examine the 3 different states of balance and postural control. And after you've completed your examination, then you can start to ask yourself why and further examine some of those other areas on an impairment level basis as needed. Being able to thoroughly examine a child's sensory systems is a really vital important of a pediatric examination. You already know how to perform some of these sensory examinations when you think about superficial sensation and some of those proprioception tests of sensation, but we're going to hold on giving you the details of these sensory tests, both primary and cortical sensation, until we get to the spring semester with our adult population. But you should have an understanding this semester how these different areas, how primary sensation such as superficial sensation or deep sensation can impact a child's ability to be able to move and function. Even though we're not going to go through and you won't have all of the logistics of how to do the test, you need to have a solid understanding of how sensory impacts motor function. And they usually go hand in hand. If you're having impairments in motor function, usually the input that's coming into the system is not quite right. So that could be lack of awareness or knowledge as it relates to where a limb is in space, which would then show deficits in being able to perhaps place a limb appropriately for stair climbing. So you don't need to know how to conduct these tests this semester, but you do need to have an understanding of how sensory impacts motor and what sorts of impairment level issues can be present here for your patients with pediatric neuromuscular impairments. There are a variety of tests and measures that you might choose to do in a pediatric examination that would fall under a more musculoskeletal exam. And you have developed a lot of skill in this area in your coursework last year, so we're going to build upon that this year and look at it from a pediatric perspective. So some of the interpretation of the data may differ from what you've done when working with adults, and some of the ways in which you gather that data may be different, but the same general premises that you've learned about last year will carry over now into this year when we talk about pediatrics. So when thinking about collecting some of those basic anthropometric characteristics, you're well skilled in gathering data pertaining to height and weight and girth, body fat composition, and body mass index. So all of that stays the same. The formula to calculate body mass index is also the same between adults and children. But when measuring children, age and gender are also factors that you would need to consider in addition to just the height and the weight. And that's because the amount of body fat that should be found in a child at any given time is going to change during development, and it's going to vary between both boys and girls. So you need to take that into consideration, and then children are placed into percentiles to show where they fit as it relates to their age-matched and gender-matched peers. As you're completing your examination, you'll want to take note of the child's skin integrity. Make note of areas that have scars or excessive bruising beyond what you might expect for a child that age, any areas of skin breakdown or calluses, so on and so forth. Essentially, you're looking from any deviation from typical skin integrity that you would expect. And these can be clues that can help you further investigate, select additional tests and measures, or also guide your subjective history, doubling back on some of those pieces as you see deviations in skin integrity. For example, you may be doing a posture assessment and end up seeing scars located on the child's back or lower extremity that you didn't see before, and that may lead you down a line of questioning and the parent ends up telling you about a surgical procedure that they forgot to mention previously. So it can give you good additional information. Another example is bruising. Child may have excessive bruising on the legs, and which kind of clues you in potentially that their balance and postural control is more impaired than an individual their age that you would expect, or perhaps their protective extension isn't where it should be. And then certainly we need to consider child abuse scenarios that could potentially be a concern for that child. A child who does not have a lot of mobility may have skin breakdown on their gluteal region or proximal thighs if they're spending a prolonged amount of time in a wheelchair, or even children who do have mobility but wear orthotic devices. It's not uncommon to have skin breakdown or calluses located where the device is on that child's body. So always a good idea to examine the skin and its integrity. You'll also want to examine the child's joint integrity or skeletal integrity in any issues as it relates to joint mobility. So you will measure range of motion as part of that assessment throughout the upper and lower extremities, but you want to know what is the integrity of the joint that you're dealing with. So oftentimes in pediatrics, children may have challenges with the integrity of their hips, frequent dislocation or subluxation, and that can really happen at any joint, including the spine. So as we move through the content for this semester, you'll learn of diagnoses that have a more prevalence for either excessive mobility. A child with Down syndrome, for example, may have what could be a dangerous excessive mobility high up on the cervical spine. And you also may have children who are prone to dislocating and subluxing due to their tone distribution in their lower extremities that's pulling that femur out of the acetabulum. And we'll cover that as we move through the remainder of the semester, but you want to be able to assess that joint and skeletal integrity as part of your musculoskeletal examination. Pain is another area that you want to be skilled in being able to examine. A child may not be able to verbalize if they are in pain, so you'll need to use other cues that the child would be giving, perhaps facial grimaces, crying, so on and so forth. So you'll need to become skilled at being able to read the child's nonverbal communication skills as it relates to pain. If you do have a child who is able to verbalize, certainly you could ask those questions if they're not offering that information, and you could use an objective scale, an objective pain scale, to be able to document that child's pain. And there are several options for pediatric pain scales. There's one included here on the slide, the Wong-Baker Faces Pain Rating Scale, and there are other scales similar to that, the Oucher's scale, and other analog scales that you would be able to use to get an objective documentation of that child's pain. You also want to know what makes that child's pain better, what might make that pain worse or exacerbate that pain, and that could clue you in on what might be causing that pain, and then additional tests and measures you might select to tease that out a bit more. An important aspect of a musculoskeletal exam is to make sure that you do a thorough postural assessment. You should begin with observation and make sure that you have areas exposed that you need to be able to have eyes on. And you want to be able to assess posture from all views, of course, maintaining the safety of the child. So depending on that child and their capabilities in balance and postural control, you may need somebody to sit by the child or to assist you in ensuring their safety if perhaps their parent is available to participate in that assessment. You're going to want to look at posture from all vantage points in a variety of planes, and this is really the same strategy that you would use to do a gait assessment. I oftentimes will do a postural examination right before I do a gait assessment, because you'll find that a lot of those postural deviations that you saw statically will then carry over into your gait assessment. So if you have a good handle of those before you start that, it might make your gait assessment a bit more efficient. You'll want to compare any deviations that you see in posture to what you would expect for that child given their age. So when a child is developing, oftentimes we expect postural deviations from a neutral alignment. And I believe those are in your Shumway-Cook textbook. But those normal kinematics for developing children. So you want to, obviously you'll need to know the age of the child and what postural deviations you're seeing, and if that is atypical for that child given that age. You should do a posture assessment in any developmental position that is functional for that child. So when I have a child who is up and ambulating and walking, running, jumping, I usually start with at a minimum a standing posture assessment, and I might also do a assessment in a seated position. For a child who doesn't have that high level of gross motor function, your posture assessment may be done in supine or quadruped or sitting. So it really just depends on what positions are functional for that child. Those are the ones that you should take a look at from posture. As far as active and passive range of motion goes, there's nothing new here to consider. The information that you learned last year and hopefully practiced on your clinical this past summer will be pulled forward and used here in this course. So want to measure and document any active and passive range of motion restrictions that could be present that deviate from what you would consider as typical. You may need to use equipment or props to help stabilize the child or make them safe during your assessment. And then spinal range of motion is the one add-on for active and passive range of motion that you will be tested on in Mastery, and that is its own individual PowerPoint, narrated PowerPoint with video. So I'll refer you to that document for the details as it relates to spinal range of motion. Examination of cranial nerves is going to come to you across a few different courses, Neurobio and PT 545, which is our adult rehabilitation course that will be in the spring. So we won't be covering cranial nerve exams specifically this semester, unless of course it pertains directly to your patient in clinics, and you can work with your faculty mentor in being able to appropriately examine those involved cranial nerves. So there's an asterisk next to the slide. We're going to hold on this content until the spring semester. Next, we'll briefly talk about cardiovascular and respiratory assessment. You already have skill and content development in this area, so we're not going to go back through that. Nothing changes about the psychomotor aspect of how you would measure heart rate or blood pressure or respiration rate. So you're well skilled in that. The aspect that might be different is that you need to then compare that to age normative data. So for example, a newborn child is going to have a much faster heart rate and respiratory rate as compared to what a resting rate would be for a 10-year-old child. So you need to know the age of the child and then make those comparisons as to whether or not what you're seeing is typical or outside that normative range that we would expect. A lot of the pediatric folks that we will see do have challenges with their cardiac system, and they may be predisposed to cardiac involvement based on their diagnosis. So that would be an important consideration when deciding if you're going to measure vitals, let's say in clinical exposure. Same would go for considerations related to the respiratory system and breathing challenges. So that information will be assessed as with any test and measure based on that individual child. As far as tests of physical fitness goes, You have information based on exercise physiology about how to calculate maximum heart rate, and you have those exercise parameters as it relates to what percent of maximum heart rate you'd like that individual to be exercising at to achieve certain outcomes. And that really is very similar in pediatrics. You would apply those same principles to any patient who is 18 years and younger. This last slide here contains some supplemental information for your reference, and I would also refer you back to your clinical medicine notes regarding birth weight and birth size and APGAR scores and what those definitions are and what those numbers suggest. Additionally, something to continue to keep in mind when we talk about corrected age or adjusted age, you may see that listed as it relates to a child who is born premature. Most parts of the country will correct up until that child turns 1 year of age. So they will make that mathematical correction based on how early they were born and subtracting that value off their chronological age. However, in the Western New York area and a bit beyond, we typically correct for the child's prematurity up through age 2, so until their second birthday. And that seems to be specific to this part of the country. So you will see that correction happen to age 2 if you remain local or you are out on clinical internships. We typically are correcting up through age 2 years.